Hey nurse warriors, burn injuries are more than skin deep. From fluid shifts to long-term rehab, managing burns requires swift action and holistic care. Today we're diving into how to classify burns, estimate severity, manage complications, and provide compassionate nursing care through every phase of recovery. Burns are categorized based on depth of tissue injury. Superficial or first-degree burns affect only the epidermis. They are red, dry, and painful like a sunburn, and they heal in days without scarring. Partial thickness or second-degree burns involve the epidermis and part of the dermis. These burns blister, are moist, and very painful with a risk of infection and fluid loss. Full thickness or third-degree burns extend through the entire dermis and may reach subcutaneous tissue. They have a waxy, leathery, or charred appearance and no pain in the area due to nerve destruction. Fourth-degree burns may extend to muscle and bone. The rule of nines is used to estimate total body surface area, or TBSA, burned. The head and each arm represent 9%, each leg is 18%, the front and back of the trunk are 18% each, and the perineum is 1%. TBSA and depth help guide fluid resuscitation and triage decisions. Major burns, which are 20% or more TBSA, can lead to burn shock and multi-system involvement. Fluid shifts occur as capillary permeability increases, causing plasma to leak and resulting in hypovolemia with massive fluid and electrolyte loss. Electrolyte imbalances include hyperkalemia early on, followed by hypokalemia and hyponatremia. The risk of infection is high due to the loss of the skin barrier, leading to a high risk of sepsis, immunosuppression, and open wounds. Metabolic demands and organ dysfunction are also concerns, with hypermetabolism, insulin resistance, and risks of acute kidney injury and respiratory distress. Phases of burn care and nursing interventions. The emergent phase, which spans 0 to 72 hours, focuses on several critical priorities. First and foremost, the ABCs: airway protection, breathing, and circulation. Fluid resuscitation is crucial, typically using lactated Ringer's solution and the Parkland formula. Pain management is essential, with intravenous opioids being preferred. It's also vital to monitor urine output, vitals, and signs of hypovolemia closely. In terms of nursing care, inserting a Foley catheter and establishing large-bore IVs are necessary steps. It's important to keep the patient warm and free from infection. Providing emotional support to address trauma and fear is also a key aspect of care during this phase. The acute phase, which lasts from 48 to 72 hours until wound closure, has its own set of priorities. Wound care is paramount, involving debridement, dressings, and hydrotherapy. Nutritional support is also critical, emphasizing a high-protein, high-calorie diet. Preventing infection through aseptic techniques and administering antibiotics if needed is essential. For nursing care, monitoring electrolytes, glucose levels, and wound healing is necessary. Pain control, especially during dressing changes, is a priority. Supporting the patient's mobility to prevent contractures is also crucial. The rehabilitation phase begins from wound closure onward, with the primary goals being to maximize functional recovery and independence, and to prevent scarring and psychological distress. Nursing care during this phase includes promoting engagement in physical and occupational therapy. Teaching the use of pressure garments and scar massage is important. Supporting the emotional health of the patient, possibly through referrals to counseling or burn survivor groups, is also vital. Burn care is complex and often lifelong, but with skilled nursing interventions, education, and empathy, we don't just heal the body. We help restore dignity and resilience. Have you cared for a burn patient? What helped them most? Share your tips in the comments. Like, subscribe, and follow for more emergency and critical care breakdowns, designed for bedside brilliance.